after the lockdown, people were stressed about everything. They all went vacation. Right now, beaches are crowded, so nobody seems to care about COVID or PPE or mask or whatever. So the cases are increasing. So
Yeah,
it's going to be worse probably in fall or something. So we'll see.
yeah. It's just so hard to really kind of just nail down what to do. I mean, I think Canadians we've been a little bit more cautious, I guess. But we still have our areas where we've had some increases.
Yeah, probably. So it's increasing. It's kind of increasing in UK or Spain, and yeah, I used to talk with friends from there, from Europe. So they're telling the same thing.
I see some people have joined us from
Mhm.
Honduras and Indonesia. Look at that, and New York.
It's nice.
Have you been to Indonesia?
No.
No.
Ooh,
No, I was supposed to go. I mean, I was supposed to go so many places.
really? You haven't been? Wow.
This year, I can't even count how many trips I've canceled. Really,
Of course.
Even Turkey.
You have to do that.
Is your meeting still on in November?
What?
Is the Turkish meeting on the Turkey national?
They are still talking about that, but probably it's going to be virtual. So it's impossible.
Yeah, yeah. I'm sure. I know people are holding out to try to see if their meeting will still go on, but
Yeah.
I think it's.
I mean, it's so dangerous. Hundreds of people cannot, get together. It's very dangerous at
Yeah,
this point.
yeah. I know. I think I don't think we'll have a physical meeting until the new year.
New Year, yeah, maybe next year.
Next year, man.
A lot of
Really sucks.
meetings, are canceled to the second half of the next year or something.
Yeah,
As
yeah,
far as I know, so.
yeah.
So I'm very concerned about the schools.
Yeah, that's another problem too. That's probably the biggest controversy now because it's now school season, kids getting back to school, and it's a lot of difficulty and challenges with what to do for school. Let me just check the YouTube connection. I just heard that it wasn't very stable, but I think it's. Let me see here. We're gonna get started in just a few minutes. I see we have people joining us. So this is Zainab here. Zeynep Bektaş from Ankara. Thank you for everybody for joining us.
Thanks for the invite. Thank you.
And we do have Imran Masood from the UK who will be with us shortly. But right now we're just chatting in general. It's nice to see people from. We have a pretty good. Well, we have some Libyans and some Saudi Arabians and some Indonesians, some Brazilians. I was counting a few Brazilians to come. See if there's any Turks coming here. They're all at the beach, right?
Yeah, most of them.
So you were seeing a patient today. Today's Saturday. Do you normally work on Saturday?
No, not yet.
Not yet. Yeah, not yet. So what was this patient, like a post-op or was it an urgent patient?
Yeah, it was post-op.
Yeah.
Patient. Yeah.
What was going on?
It's great.
Yeah, of course.
So another reason I came here is the internet connection is more stable here. So this is another reason for me to be here.
We appreciate that. We appreciate that. I mean, I know it's in the middle of your day here. We always try to grapple what the right time to do these rounds are. Like we've done them in the evening, we've done them in the morning. When the pandemic was first going on, it was like we could do it like in the middle of the day and everybody was available.
Yeah, but now it changed.
Now it isn't. So, anyways, it's good to get for us in Canada, Saturday morning isn't usually too bad. So, When was the last time you traveled?
In February to London.
Oh yes, okay.
It was a lot of fun. But we were wearing masks.
In February by then.
Oh yeah, in February, and then everything got worse suddenly. And we got back here in March, and lockdown started.
Yeah, I know. It's for me it was March 7th. to
March
Columbia.
7th.
That was kind of close. That was probably, I was debating whether I should actually have go to that meeting, but I did go. And then literally I came back home, and then 2 days later I was supposed to go to Dubai in Egypt. And then just everything kind of just went. So
lockdown didn't start at this time, right?
No, it started March? About for us it was basically about a week later.
Week later?
Middle of March, yeah.
Mid-March.
Yeah. Yeah. And for you guys?
Same year.
Yeah. Okay. And your practice now, is it busy? Are you working?
Yes, it's kind of busy, but now we are now everything's getting worse, and we are trying to find a way for this. Probably we're going to slow down again, so it's getting worse but it's kind of crowded. So last week there were a lot of people in the clinic.
We're finding there's still people don't want to come in, especially cataract surgery. I think a lot of people are kind of like, I can put it off. But for glaucoma, I mean, I think and complicated surgeries, people are have been coming in. I see we got Matthew here too. Matthew's one of our fellows, so we have a couple of Irfan and Matthew. You guys can shoot us some questions, or maybe if there's questions that come up from the chat group during Zainab's presentation, you can. Just blurt them out.
Ask, yeah.
Sounds good.
Great. Okay, so we'll get started. I'm just going to share my screen first to get started. So thank you all for joining us. It's Saturday morning here in Toronto, and I know it's 3:00 p.m. in Turkey, which is where Zainab is calling from. We appreciate her time being here, and let me just get us started. So so this is our I don't know, actually I lost count. I think it's probably our 25th or so Prism Eye Rounds. We started out during the initial stage of the pandemic, and then we went crazy, and we went it was busy, and then we got busy, and then we basically kind of paused a bit, and then we're back now again. And there was enough interest to say we should keep it going, so we kept it going, and we've had such great people to speak, including Zainab in the past. And so we appreciate you all being here. I know that some of you are on YouTube as well, so it's great to see you here. And if there is any interest in a specific topic or even speakers, and let us know. You can email us at the email on the page. And for those of you that are looking for CME credits, this is Section 1 credits, and so you're welcome to claim those. And for those of you that are submitting or here at the meeting, we'll be sending you a link to download a form to do that. I've been told that our Zoom link maybe there's an issue with our Zoom link, but I think most of you are here, so hopefully it's working. Okay. So one announcement: our next rounds will be on Sunday next week, not Saturday, but Sunday. We moved it to Sunday for next weekend, moving the dates around a little bit. So hopefully we'll see you there at 8:00 in the morning. And apologies for those on the West Coast because it's pretty early for you guys as well. So today we're talking about small things, but big problems and big issues. I think you'll enjoy both of these cases. Both Dr. Zainab Akhtas and Dr. Imran Masood have prepared some really interesting cases, and we look forward to having the discussion. So our learning objectives here are managing challenges and complications of cataract and glaucoma in small eyes, management of angle closure, and complication management in angle closure. So those are some of the learning objectives that we wanted to achieve today. So let's talk about Zainab Akhtas. She is from Turkey. She did her training at Gazi University in Ankara, and she did a fellowship at the University of Wisconsin. And I think they almost were able to keep you there, Zainab, but you managed to get back to Turkey. She's now director of glaucoma and associate professor at Gazi University, where she trained, and she's been quite involved with the ICGS, International Society of Glaucoma Surgery. I got to know Zainab. I think I met Zainab in Where was it, Zainab? It was like in
Finland.
Helsinki. In
Yeah.
Helsinki, yes. I was doing a talk, and then we chatted, and I could immediately tell she was really very brilliant in her thinking and asked really good questions. Very dedicated clinician, and if you talk to her, she manages very difficult and complicated cases, and does it very gracefully back home. And she's published. She continues to try new things and innovate, but also ensures that there's a good science and evidence behind it. So we appreciate you being here, Zainab, and joining us here today. And I know you've always had some interesting cases to share. Our second speaker is Mr. Imran Masood, who's from Birmingham. He is actually just in the middle of doing a surgical case that came in. He just messaged me earlier today. Hopefully he'll be able to join us soon. But he's based out of Birmingham and Midland. He has some connections to Toronto, actually, and has visited us a few times a few years ago as well. And also very busy glaucoma and cataract surgeon. He has been innovative in bringing new instrumentation and new devices to England, as well as being part of clinical trials. And so I think we've got two really great speakers who are here, who can, I think, really share some great pearls with cataract and glaucoma management. So I will stop sharing my screen, and Zainab, I will pass it over to you to get started. And again, as always, those of you that are here, please feel free to ask any questions you may have. And you can use the chat box, or you can use Q&A. I'll ask Matthew and Irfan to just monitor the Q&A in the chat box if there's something that comes up. I'm sure, Zainab, you don't mind if we interrupt you when you're talking, just to ask a question or two. And same with Matthew and Irfan. Irfan, if you have any questions,
Yes, please.
we have some tough fellows here, Zainab. They're pretty tough. When I'm in clinic, they ask some pretty tough questions. I got to stop and think for a little bit, So these guys are pretty sharp.
This is great.
Sounds good, you guys.
That's what I'm looking for. Okay. You see my slides, right?
Perfect. Great.
Okay. Thanks again for the invite, Ike. It's a great pleasure to be with you again and present this case, this challenging case. So today, as you mentioned today, I brought an interesting case here. And I'd like to discuss some important considerations when working with small eyes and shallow ACs. So this is a 35-year-old female patient referred to our clinic for the evaluation and mostly for the surgery of the left eye. And she had small eyes, and her visual acuities were 0.7 in the right and 0.6 in the left with high hyperopic correction. And the right eye was pseudophakic, and the left eye was phakic. And she had also glaucoma, and it was very well controlled with medications. One medications in the right, and the two medications including brimonidine and nimatoprost in the left eye. So when it comes to patient's ocular history, and as I mentioned, patient underwent phacoemulsification in the right eye a couple of years ago, and she also had a well-controlled glaucoma. And interestingly, surgery was urgently recommended for her left eye, and she came to me with her lens. She was holding a lens IOL box in her hands, and she was ready to go. So it was a very difficult situation, and lens was plus 48 Zeiss lens. So let's see the patient here. In the right eye, you see a deep anterior chamber. This is you see my cursor, right?
Yeah.
It's the PI, probably the previous IZ-HV area. And the left eye has a little bit shallow ACs, but it was not that bad, and lens was clear. So what about measurements? Axial lengths were around 16 millimeters in the right eye and 16.2 in the left. White to whites are around 11 to 10.8 millimeters, and the IOL measurements calculations revealed plus 50 diopters. And when you see as you see the orbital ultrasound, there was increased choroidal thickness and sclera as we expected. So these measurements were consistent with case with non-ophthalmos, of course. So if you look at the anterior chamber depth, it was 2.25. You see here the lens wall, and glaucoma was very well controlled. Actually, you see here the right eyes OCT and left eyes OCT, and visual acuity visual field were totally normal. But of course, in these small eyes, both visual fields and some OCT images are not so reliable because of the high refractive errors and the short axial lens. But her optic nerves were looking good. So at this point, I would like to stop and ask you, would you operate her? How would you proceed? So let's discuss. And when would you operate? Do you have any criteria? You know, in these patients, planning is so important. In terms of, do you have any criteria in terms of age, AC depth, and presence of glaucoma and cataract? How do you decide?
Yeah, I think this is really the first question to ask, of course, because we know the complexities in these eyes.
Mm-hmm.
I think that there are a couple of things that are important, of course. I think that there's always a balance between doing it too early versus doing it too late, right? No matter how great the surgical procedure is, doing it too early, there are complications, and then waiting too late when there's synechia and glaucoma and more shallowing is also a problem as well. I typically generally like to observe if I can. If there's no synechia, if the pressure is good, then I typically wait. I usually wait for somebody to have some evidence of pressure elevation or glaucoma. In your case, or of course if there's extreme shallowing, and I think that's something that is probably more variable in terms of when to intervene. Obviously, a very, very shallow chamber with iris contact to the cornea would also significant iris contact would imply earlier intervention. But I don't think there's really a firm guideline in terms of when to proceed and when not to proceed. The good news is this patient had surgery in the other eye, which is a similar size,
Mm-hmm.
and is doing well. That's good news, at least, right? So you have some history and some experience with it. So those are some of the things I would consider. What about yourself? What has been your approach in managing these cases?
Yeah, it's exactly the same. So this is good news. Patients is doing well with fellow eye. But in this case, of course, I first tend to follow these patients. I used to see these kind of patients here in Turkey with small axial lengths, and patients with non-ophthalmos, with shallow anterior chambers. And I tend to follow them and monitor them if there's no, cataract. If the patient is, in their early 20s, if the lens is clear, there's no sign of glaucoma, and anterior chamber is like 2 point something, as more than 2 millimeters. So I kind of follow these kind of patients, maybe 2 times or 3 times a year or something. In this case, so IOP was controlled, medications are well tolerated, and optic disc at least was looking good. So we decided to monitor her at this point.
And how long ago was it that you saw? Okay, for 3 years ago. Okay, got it.
Yeah, it was 3 years ago, exactly. So so during follow-up, IOPs are, were same. There was no, sorry.
Can we jump in here? There's a good question
Sure.
coming in from the from one of the attendees wondering, was the patient at all bothered by her anisotropia given her unilateral surgery?
Mm-hmm.
It's a good question. So I guess yeah, good question from Ramsey about patients plus 12 and yeah. I think plus 1. Were they bothered by the anisometropia? It's a good question. Or were they wearing contact lenses?
Not much, but because patients was very well aware of the risk of surgery in non-ophthalmic eye, so he was not insisting on having surgery, but she was kind of, showing the intraocular lens in her hand, she wasn't so much disturbed by the refractive error at that point, at least.
And by the way, I just spontaneously brought on Maria Fernandez from Colombia, Dr. Delgado. So if you're interested, Dr. Delgado, you always have good questions to ask a great glaucoma specialist from Colombia. I didn't ask her to be on the panelist, but I just saw her name here, so I brought her in. So if you're free, Maria, please feel free to speak up. So, but one question is, I mean, for this patient, I mean, so how'd they get the lens? Because this lens is, I mean, they must have been planning to do both eyes, and I guess the surgeon decided not to do the fellow eye. Like, what was the story behind that? Do you know?
She was seeing another colleague, and probably he was planning on doing surgery in the other eye, and then she decided to go and see other colleagues, and then came to see me.
Okay, interesting. Okay. All right, so you decided to observe. I think that's not unreasonable if she wasn't totally bothered by anisometropia.
And she was wearing nothing, eyeglasses or contact lenses, and she was pretty comfortable. That was interesting, yes. So during follow-up, IOPs were same. No, there was no progression, and she had no complaint, and she was seen each 3 to 4 months, and she was living in another city. And during that time, LPI was performed in the right eye. In the left eye. So she stayed same for 3 years on 2 medications. So this was 2 months before the last visit, before her last visit. You see here the anterior chamber depth is quite same. It's 2.29 here. And you see here the OCT images of the follow-up of the left eye here. It's quite stable too. And then 2 months later, she showed up like this. IOP was still in low teens with 2 medications, and she was no pain in the left eye, interestingly. And IOP was, IOP was very interesting to me. It was first time for me to see such a patient, such a case in terms of low IOP. I mean, so she was, she had no complaint, basically no pain, but she was telling that, you know, kind of decreasing vision. She was feeling like her vision was getting worse in the left eye, and visual acuity was really decreased, actually 0.1. And you see here the flat anterior chamber, and iris was almost touching the corneal endothelium almost everywhere. And in the central area, just right over the anterior lens capsule, there was a thin membrane here, and this was probably the reason for her to see worse. And what about the measurements? You see here, this is probably the measurement error. You see this, you know, with lens vault increased here almost at least 2-fold, and it's touching the cornea. You see the touching areas. Anterior chamber was horrible. It's flat. So in those cases, we should definitely go check the posterior segment and do ultrasound just to rule out any other posterior segment pathologies as a rule. And you see here nothing else in the posterior segment except increased choroidal thickness and thick sclera, which is expected finding in patients with non-ophthalmos. And this UVM of the left eye is horrible. I'm so sorry about that, but all I can say that ciliary body is slightly rotated anteriorly. And here, this is interesting. I would like you to pay attention to this area, ciliary body of the right eye. It was kind of located, positioned anteriorly, and there is no supraciliary sulcus. So maybe at this point you can make comments.
Yeah, I want to pause here for a second because this is fascinating, seeing a 3-year progression and then a sudden progression in 2 years. I also brought on Steve Safran. I don't know if Steve or Maria are able to speak. Anybody else who wants to participate, I'm happy to bring you on stage, so to speak. If you are, let me know. Just send me a message on the Zoom chat to do that. I see Ahmed Mansour is here. I'd love to see Ahmed Mansour. Let me see if I can bring Ahmed Mansour up here to be on the panelist.
He actually had a question about thickening of the sclera. I wonder if you can comment on that in these non-ophthalmic eyes and how that affects things and how you treat that.
Yeah, so I think it's a good question as far as just the scleral thickness and what the impact is of what's going on. But I wanted to just, and I want to make sure we address that. But I wanted to maybe first ask, like what exactly is going on here? Oh, you gave some of the potential answers here, but and Ahmed Mansour, Ahmed, if you're here, we'd love to hear from you. Ahmed is from Lebanon, man, and we're certainly are thinking about you and your country mates in this difficult time with the situation in Beirut. So our prayers are with you guys. I'm happy to see you here, Ahmed. If you're able to join us, please unmute your microphone if you'd like to. But I think the question is what's happening here. Why did we see this sudden change? And of course, the next one will be how do we manage it?
Yes, sudden change in 2 months and with low pressures. Yeah,
and that's another thing too with low pressure. So I see there's a few comments in the chat box. So I see misdirection, I see malignant secondary to LPI. The LPI was done when? In that
a year ago, something.
Okay. And again, yeah, so we're seeing a few misdirections, malignant glaucoma. So it certainly appears to be some form of malignant glaucoma. I think choroidal effusion is one of the other things to think about, although your B scan, I think, showed not so much an effusion, but more a thickening. It was hard to look at the UBM, as you said. If you can go back to the UBM, it would be interesting to see the presence of a superciliary effusion that can do this. What's a little bit unusual is that if this was malignant glaucoma,
there were no superciliary effusion here. But this,
it's hard to tell exactly for me here, to be honest with you. But I'll take that.
I saw the UBM images, but then we realized that they were not saved. So this is the one we could save. So I'm so sorry about that. But there was no superciliary effusion, that's for sure, and nothing in the posterior segment.
Got it. Because what's unusual is, I mean, with malignant glaucoma, without the presence of a bleb, without the presence of a scleral opening, you would expect the pressure to be quite high when the chamber is this shallow. You'd expect that, right?
25 or 20 in the beginning, in the very beginning. This is quite low. And this has happened, as you said, if there's a presence of glaucoma or filtering surgery, history of filtering surgery, you can see that low pressures. But this is very interesting. I would expect at least 20 or 25 millimeters mercury pressure with the beginning of the malignant glaucoma. So this is really weird.
Absolutely. So when I hear that story, for me, it's more like is there some sort of effusion, maybe causing a ciliary body detachment, causing the chamber to shallow, but also causing hyposecretion, right? We know that when the ciliary body detaches, you can get basically hyposecretion. The ciliary body, doesn't function normally. So even though it's pushing the chamber, shallow, the fact that it's detached now, it may result in less aqueous production, and that may be the reason why it's balancing. This is what my theory would be, but your imaging doesn't seem to indicate that. Let me bring in Ahmed. Are you here? Are you able to speak, Ahmed? I think is unmuted, but maybe he's not able to speak. So Zainab, I mean that's what's really unusual here. That is what's really unusual here in terms of
unusual, yes. In terms of especially intraocular pressure. So let me go ahead. So spontaneous malignant glaucoma is a rare event, and it's published previously in the literature. It's characterized by spontaneous, or after the operation, is characterized by anterior rotation of ciliary body, shallow AC, centrally especially, and forward displacement of the iris, as we know. And there is a increased transvitreal pressure. And yes, you're right. These non-ophthalmic eyes and small eyes have a tendency to have malignant glaucoma, because increased transvitreal pressure cannot be easily equalized in non-ophthalmic eyes. So this might be an option. Another option seems to be a plato iris and phacomorphia and high lens rise. So let's remember what this is all about. So in plato iris, central AC might be normal. And in phacomorphia or high lens rise, especially central AC can be expected very, very shallow. And this is called volcano sign. And this is actually what we have here in our case, and also we have a plato iris or anteriorly positioned ciliary body here in this case. So what do you think at this point?
Yeah, I just saw Ron Feldman here talking as well. So I brought Ron. If you're free to talk, please say a few words. Ron is an incredible surgeon and clinician. So I don't know if Ron is able to speak.
Yeah. Great to see you, Ron.
How are you, buddy? Nice to see you from Dallas. The big D.
The big D. Yeah, yeah,
How are you?
Good morning, everyone. Yeah, this is a fascinating case for sure. So if I understand it right, the case started off, it was just kind of a shallow chamber in an anophthalmic eye. And now years later, it's converted to the chamber is shallower and there's a annular ciliary, or at least an annular superciliary effusion. Is that right?
No,
that's what I was suspecting, Ron. As you said, I mean, you know, I mean, it's really unusual why the pressure is low and the chamber's basically flat. And I agree with you. I thought I would have suspected there might have been an effusion, although the UBM I think wasn't quite clear, right, Zainab? You weren't clear about the fact that there was any kind of effusion annular.
Yeah, that's right. But there was no effusion. We looked for that, but there was no effusion. This was the only picture we could save. And I brought this picture here, but that's for sure. There was no fluid. That's what that's the first thing we checked, but there was no fluid. So that's why we were talking about. That's why I brought this case here, because there's no history of glaucoma procedure, so pressures are very low. It's very interesting.
Okay, so even when you looked at the ciliary body, under the ciliary body, there was still no fluid. I know there was none posteriorly, but there was no fluid under the ciliary body on your UBM?
Yeah, no.
No, okay. So you have to say what made the chamber go shallower. And that's what you're thinking about now. So you're assuming the ciliary body, maybe the ciliary body or the superciliary space, or just the suprachoroidal area somehow got larger, but we can't really measure it. Something had to cause the chamber to shallow more, correct?
Right.
Correct, and I think you're absolutely right. I mean, so I think there's a few things. I mean, the zonules, are the zonules so bad that basically everything lucks forward, right? I mean, that could be one possibility. I think Ron's point about an annular effusion, I think, is absolutely bang on as a potential. And I think we have seen spontaneous malignant glaucoma. I mean, I've seen people come back and they basically have, you know, either they've rubbed their eye or there's some event, or spontaneous where, you know, we see it. Now, usually it's after surgery, like a phaco or after trabeculectomy, and it can happen spontaneously. And then, of course, there's you know, effusions, posterior effusions, posterior suprachoroidal, you know, hemorrhages and things like that, melanoma, whatever else there may be. I don't know. I mean, it's a bit unusual, Ron. I mean, the pressure is normal, which surprises me a little bit on this one.
Yeah.
And on gonioscopy, you said the angle's closed completely on gonioscopy?
Yeah, that's right.
Optically closed, at least. Okay. Yeah, well, hey, it's Saturday morning and it's glaucoma. What do you want?
Yeah, fascinating. I mean, that image is incredible. I mean, look at that. There's like virtually nothing there in the anterior chamber, right? I mean, that iris is plastered against that cornea. That is incredible how it is. I certainly would be thinking about you know, zonules and spontaneous malignant glaucoma. That would be probably my choices if there's no effusion. My first theory would be that there was been an annular effusion causing chamber shallowing with hyposecretion, and therefore the pressure has not gone up. But as you said before, there's no effusion. So I guess your next question is what do you do, right?
Yeah.
What's our next step?
Next step is I'm going to ask you another question. Would you monitor, or would you do lens extraction with anterior approach? This is another thing to discuss. Lens extraction together with IZHV with anterior approach, and lens extraction pars plana approach, and lens extraction together with IZHV through pars plana.
And the patient, Maria's asking, the patient was using some drops, right? They're using two glaucoma drops.
Two drops, yeah.
Two classes.
Mitomycin and bimatoprost.
Yeah, got it.
How about atropine? Did you put a drop? Would atropine drop help you figure out what to do?
No, because this happened so acutely, you know. Patients came and see me, you know, come to see me in 2 months, and like this, you know, anterior chamber was flat. So I didn't have a chance to start any medication.
Okay.
The and Murtaza makes a good comment that in mild cases of malignant glaucoma, the AC may be shallow, but the pressure may not be high. And I think that's true. Yes, the pressure does not have to be very high to have subtle malignant glaucoma. But this is like not subtle. This is like really,
Flat.
you know, like this is one of the worst chambers I've seen. So that's a bit unusual and a bit strange. And by the way, I don't know what you think, Zainab and Ron. I am not a fan of the word misdirection. I don't know what you guys, what your positions are on this. We won't get in an argument here, but I typically call it malignant glaucoma. What do you call it, Zainab? Do you call it malignant glaucoma, or do you call?
Yeah, malignant glaucoma.
And Ron, are you a misdirection guy, or are you a malignant guy?
Yeah, well,
Or something
I
else?
call it, if I'm talking to my colleagues, I'll say I have a case of malignant glaucoma, but I won't use that word malignant in front of the patient.
I totally agree with you. 100% agree with you. That's why in our clinic we call it MG.
MG, yeah, that's right.
Okay, so you know, this is a tough situation here, and I'll let Ron comment too. And Ron, thanks so much for joining us, Ron. It's a real privilege to have you here, man. You are such a pillar in our community. I want to avoid a pars plana incision, man. I mean, I have seen complications even going back with the trocar 2.5 millimeters back from the limbus, because these ora serratas are so close to the limbus, these small eyes, that there's a high probability of entering the retina when you enter the pars plana where you think the pars plana is. Now, that being said, the lens is pretty shifted forward, so you could perhaps go back maybe 1.5 millimeters and hope you don't hit the lens and remove some vitreous if you felt you could do that. But I certainly try to avoid it. I think mannitol would be important here before starting. And I think, like you said before, I would certainly start to try with an anterior approach. The pressure is not very high, so you'd hopefully be able to, you know, make an incision, hit the iris if you have to, and deepen it. I don't know, Ron. What do you think? What are your thoughts in terms of managing this case?
Well, I would definitely at my age be worried. I've never seen,
Ron, you're fearless.
I know, but I've never seen, like you said, a UBM look that flat. That the whole chamber is gone. That's very unusual to see that clinically. So it makes me worry that something else might be going on I'm missing, because it's so rare to see that. But typically, so are we saying we're in the operating room now? Pretty much we're in the operating room. The question is, what do we do?
Yeah.
So you're right about, I mean, typically I find when you have an eye like this on the table, I like mannitol first. You know, I probably would have given a drop of atropine as well. And where you make your pars plana incision, almost always I find when you go in an eye like this and try to put fluid in the anterior chamber, normally you don't get anything. You don't get any deepening. Now, maybe in this eye you would, because the pressure's low. So it's kind of strange. But your point about the zonules, oh, nightmare potential there with the zonules as a reason. But I would be going probably 2 millimeters back. I'm assuming you look at the anterior chamber, nothing happens. You have to do a pars plana tap, at least to start the case. And I like the anterior chamber maintainer in these cases, and I like the anterior approach for an IZH. So that would be, I got a feeling you'd have to do a little pars plana tap just to start the surgery. That's what I typically find. And I like the idea of 2 millimeters back and hope and pray. You don't go through retina.
Yeah, that's right.
Yeah, and I think, and there's some comments on this too. There's been no harm, very little harm in doing a little cut down. You know, maybe it's hard to see the fluid. Maybe the UBM wasn't the best quality. Who knows? But before even starting entering the eye, just make a scleral window, make a little scleral cut down. You know, go back 4 millimeters and cut down. and you may be able to, you know, get some straw-colored fluid out.
Yeah,
And if you do, that could really help your case in terms of getting things started to deepen the chamber a little bit when you get in there. You still have to form the chamber with injection, but I would even in this case here for me, but before I leave the operating room, in these nanophthalmic eyes that are 16 millimeters, this patient's going to get at least one scleral window. Because I think, as Ahmed Mansour, I don't know, Ahmed, if you're able to speak, but Ahmed has pointed out that these scleras, man, these scleras are thick. It's hard to get aqueous flow, and you get congestion. I think that having a window really helps to either treat or prevent these effusions that can certainly happen after surgery. This patient may not have an effusion now, but after surgery, they're going to get one, at least a high risk for it. So I do like that. And there was a study that was done out of India that kind of implied that scleral windows seem to reduce some of the complications, although it was a small number. So I think that's something maybe I would just think from the start. Mannitol, atropine mannitol. Someone's mentioned a Honan balloon to soften the eye, scleral windows. Anything you can do before actually entering the eye would be perhaps useful.
Do you scleral windows in each patient, in every patient with that short axial length?
100% for me. 100% for me.
Yeah.
I think they're low risk, and I think that they can really prevent potential postoperative effusions and shallowing of chambers. So for my rule is 18 millimeters. That's kind of my general rule. And I think an IZHV, which for those that aren't familiar, iridozonulo high load vitrectomy, basically essentially means make a unicameral eye. Because I see Steve Safran spoke up a little bit about, you know, about the terminology as well. But, you know, just to briefly summarize what Harry Quigley has presented many years ago, this is the phenomenon in small eyes with thick scleras and thick choroids where the choroid expands. And there's very little room in the eye. And the choroid can expand 10-15%, and yet, you know, the eye can compress significantly with that small increase in the choroidal thickness, considering how big the choroid is in a small eye. And that compresses the vitreous, and it reduces vitreous conductivity, and it pushes things forward. Now, in an eye that's big, in an eye that has an opening in the middle segment, it can prevent shallowing of the chamber. But in these small eyes, there's nowhere for that pressure to go but forward, and they shallow. So the communication between the front and back of the eye is helpful to balance out the pressure from the back and the front, and that's basically what an IZHV does. And I don't think the patient needs a flow vitrectomy in this case. So that's what I would say. And I'd be prepared, as we talked about, for zonular problems. I mean, you may need some capsular tension devices and rings, and leaving the patient aphakic, it's a challenge because this patient's such a small eye as well, right? You know, and they're refractive error.
We have a lot of challenges.
So you got a big challenge here.
Yeah. Okay. So I'm going on. So we planned lens extraction and anterior approach. So I used to go ahead and do a pars plana vitreous tap in those cases. But as you said, in this case, since the IOP is in low teens, and we didn't, in this case, we didn't plan preliminary pars plana core vitrectomy here, and also thought that lens can be pushed back easily with the aid of IV mannitol and general anesthesia and OVDs. So we go ahead and did lens extraction through anterior approach in this case. And as you said again, right after we enter the anterior chamber, of course, we hit the iris. This is what happens in those eyes. You see here the corneal endothelium, and it's scarring the endothelium here. And after injecting some OVDs, some cohesive OVDs in the anterior chamber, we started to do some goniosynovial here. And then, again, injecting some viscoelastic to create some more space, and it wasn't that bad. We have space right now. So now I'm dealing with the posterior synechias. It's very stiff. I'm trying to release the posterior synechia using OVD, spatula, and hooks here, and very kind. And now we release them all, and then inject some more viscoelastic, and then insert iris hooks to pull the iris to create some pupillary space here. And when I touch the lens, actually, it's not that stable, as you see here, but it's not that bad. The other problem is the thick anterior capsule here, so I needed to cut it And as you see here.
Just a question, Zainab, and Maria asked this question, was this under local or general anesthesia?
General anesthesia.
Yeah,
And we gave IV mannitol, as you see here. Eye is very soft, so I was quite comfortable during the operation.
I think that's a good approach. I like that idea. We don't want to block this patient topically. If they're squeezing and stuff, it's going to potentially aggravate the problem. So I think a general is a rare situation in lens surgery, but here I think it's quite useful.
In these eyes, this is my routine. I used to have patient under general anesthesia. So now I'm stabilizing the capsular bag with the hooks here. So as you said, at this point, I would insert the CTR or something else, but in the OR, the only CTR I had was 14 millimeters ring CTR. So I didn't prefer to put this ring in the capsule. So it was, you know, quite stable here, but of course it's moving. It's not healthy. So when it comes to phaco, I prefer not to use high phaco energy. Actually, you see here I'm using only aspiration. I'm aspirating the lens because cornea is diseased right now. Cornea is not good. So I'm able to put the lens in the capsule here. So again, the last 5 minutes of the recording is not here. So it stops somehow, I don't know. So I basically enter the anterior chamber and the LPI area and enlarge the PI anteriorly and do some vitrectomy and hyalotomy here, as I'm going to show you in the post-operative picture here. So this is what happens. So I don't like it, basically. This is third post-operative day. Still, iris is touching the corneal endothelium. So it's, you know, we have some AC here, but for a non-ophthalmic eye and also for the corneal, for eye with corneal decompensation, this depth, this AC depth is not enough. That's for sure. And it's 1.84. And this is how it looks on third post-operative day. We have some AC here. Cornea is, you know, there's a corneal edema, and patient is seeing 0.2 here. And she's happy with the result, but we're not happy with the result. You see here the enlarged PI that I mentioned here. And then we plan another operation, and then we go ahead and enter through pars plana here to do more vitrectomy to create more space. Maybe we can do this in first operation, but this is kind of step approach. So I didn't plan it actually, but after the fourth operation, I didn't like the depth of anterior chamber. So after core vitrectomy, you see here the visibility is not good because of the corneal edema, and we did some core vitrectomy here, and just to make sure, I am directing the vitrector superiorly here and pushing it through the PI, and just to make sure that it's still patent, I'm doing more iridozonal hyalotomy, and I would like to see the tip of the vitrector in the anterior chamber. And then add some more synechialesis here in the periphery. It's still attached here. And then end the operation. So let's see the change, the overall change here. This is after the first operation, and this is after the, this anterior chamber is after the second pars plana approach, second operation. And now when the anterior chamber is 3 millimeter here, it's not that good. You see this hyperreflective spots here. This is where iris touched strongly to the cornea endothelium. And you see the change here. This is 3 days after the first operation, and this is 3 days after the second operation. Corneal edema is better, and IC is deeper, and visual acuity increased just a little bit, 0.4, and patient is satisfied with the result. Now we are monitoring the patient. She's still on 2 medications, 2 anti-glaucoma medications, and also hypertonic sodium chloride because of the corneal edema, and residual reflection is plus 3 diopters. So let's look at the UBM images. And as I showed you before, after a couple of years after phacoemulsification, there's still the anteriorly rotated ciliary body and no supraciliary space here. This looks like plateau iris, and same here after the 10 days after the operation. And IOPs were good. It's still in low team with 2 medications. And at this point, maybe you would like to make a comment on this. ACP, if I would have ACP, I would do that, because in these cases with anteriorly rotated ciliary bodies, it works very well. It might be a good addition at this point during the operation. What do you think about this?
You know, I do think there's a role for the use of endoscopic laser to do a plasty effect to rotate the ciliary bodies back. Mm-hmm. I think we honestly, I mean, as much as I've been a big fan, and I probably was one of the first ones to start it, I don't know if we know where it fits yet. You know, I think I think lensectomy alone is an effective procedure for angle closure. I mean, in this case, your pressure is great. And I think you probably don't necessarily need it, although anatomically, yes, it does look a bit concerning here. But I think, yeah, I mean, the downside of doing a gentle plasty with the laser, not a full, blast in the ciliary body, but just a gentle ciliary body ablation to push them back is generally pretty safe, and can buy you maybe 100 microns or 200 microns of deepening in the periphery. So it's a consideration, but I don't know if you would have to do it. I don't know if it would, how much difference it would make. I don't know what you think, Ron, about ECP here in these eyes.
Well, the first question is, looking at the UBM, is the ciliary body process rotated back at all after the surgery, or it didn't change at all? I can't really tell.
Just a little bit. Just
so
a
it
little.
came
Of
a
course,
little.
It changed, but I can't see any supraciliary space here, just like the right eye. So do you think that this looks like plateau iris?
Yeah.
I guess on gonioscopy, I don't know if you can see in there yet, but can you see the angle? Has it opened?
In the left eye? In the left eye?
Yeah, the eye you operated on.
Yeah, it's open. It's open, but it's quite, it's not occludable, that's for sure, but there's something here. Also visible in gonioscopy, that's right. It looks like to me a plateau iris associated with nano-ophthalmos.
Yeah, I agree with Ike. It's plateau iris probably, but what to do with the ciliary body and ECP, mm-hmm. I don't know exactly. But Ike mentioned something interesting that I've noticed that's a little different. And that is, in a scleral window in a nanophthalmic eye, Ike, I usually see clear fluid. And I know you mentioned yellow fluid. Have you noticed the difference in the nanophthalmic eye? Now, typically, it's a nanophthalmic eye that has a high pressure that needs the scleral window. When on UBM especially, you see the superciliary effusion. Mm-hmm. And I find when you get the little bit of fluid on those cases, and I love windows. I like windows. I would have probably done a window in this case, because with my luck, doing everything so far that looks perfect and beautiful, I'd still have a shallow chamber and have to go back and do a window with my luck. But I find the fluid is usually clearer than when you're draining the typical choroidal effusion with hypotony. Have you noticed that or no?
It's an interesting question. I mean, I have noticed it. I haven't differentiated clear from a little bit of straw colored yellow nature to it. I'll have to go back on my videos and look at it. It's interesting, an interesting comparison. I would say that I've seen generally some tinge of color. I don't know. Perhaps it depends on the duration of how long the flu has been in there. That could be a difference too. Often we wait a bit in these hypotony cases, and maybe if we go in early on these high pressure cases, maybe that they're less likely to have that tinge of yellow. And so, it's an interesting observation. I'll pay more attention to that, Ron.
Good. It might help us figure out the mechanism of what's happening. I think there's less albumin in these nanophthalmic eyes, but it'd be interesting to look at.
Very good point.
Okay. Now,
Well, that's a pretty fascinating case, Zainab. I don't know if you have anything else to finish off with. That's incredible.
Thank you. So you see here, so I'm wrapping up. So you see here the anterior segment OCT images of the same of the case, and we still have healthy endothelium here, as you see here. So, okay, I'm going to wrap up. So, the nanophthalmos is characterized by short axial length, marked hyperopia, and we expect no major ocular malformations. These are healthy eyes except thickened sclera. So we have lots of challenges we discussed. We have preoperative challenges related to IOL power calculations and intraoperative sudden AC changes, shallow chambers and positive posterior pressures, and some challenges related to implanting high dioptric IOLs. And we mostly see these postoperative problems in those eyes. This is another non-ophthalmic case with 19 millimeters axial length. And after iridozonal hyalodovitrectomy, we still have high intraocular pressures together with open angles. And I did GAT in this case, and everything went well, went so smooth. But despite that, we still had self-resolving choroidal effusions in this case. So whatever you do, you see these kind of problems in those eyes. So I would like to remind you key points. Mannitol, we talked about that. You should maintain stable AC. You should pay attention to the endothelium in patients with shallow ACs, and phaco settings are important here. Sudden shallowing is very important. This means choroidal effusions until proven otherwise. So you need to do scleral cut down. So we talked about it. So IZHV is very important in those cases. During IZHV, in the very beginning of the procedure, you should direct your instruments toward the optic nerve in small eyes and away the lens, not to hit the lens. This is an important point. So lens extraction is essential, and when to do that is very important. So we need to balance, as you said, the risk of angle closure glaucoma and versus surgical complications in a non-ophthalmic eye, large lens, anterior rotation of the ciliary body, and posterior pressure. They're all characterized features of malignant glaucoma. And IZHV aims at communicating AC and vitreous cavity, creating unicameral eye. And GSL is a goniosyncolesis, and sometimes ECP might be a good addition. And the last point, maybe if we have time to discuss, would be if pressure so high in the very beginning, or in patients might have advanced glaucoma, you might need to add adjunctive glaucoma procedures. Then what would be your choice? It would be great to hear that, what you guys would do. So I would like to thank you for the invite again. And
Zainab, that's an incredible case, incredible case, and incredible surgery. Wow, that is a lot of courage, a lot of courage. I think for many of us, we would maybe hit the referral button on that one. That's a great case. It's interesting to make the question about when do you do a glaucoma procedure with the lens surgery. And I never say never or always, but I rarely would consider combining a trab or a tube in these tough nanophthalmic eyes. I would always start with lensectomy and goniosyncolesis, as you say. I may consider to do an angle procedure. We have Mr. GAT here himself, Ron Fellman, as a consideration, or using stenting as an option or something like that if I felt, because we know chronic apposition and particular synechiae may result in TM dysfunction despite opening the angle. So, but I would usually wait until I really had to do a filter. I don't like to do filters in these eyes. These are challenging. I usually wait, and even if I wait 2 months later and do a filter, I'll rather do that way. I don't know. What do you think, Ron? What's your approach in these cases? Even if they have somewhat advanced glaucoma, I would still be reluctant to just rush into there. That's my bias.
Yeah, I agree. The part I missed, Zainab, was was it the same eye you did the GAT on, or was that a different case?
No, this was another case.
Okay. So
with
let me
19 millimeter axial length. So nowadays I'm trying to do GAT in these kind of cases. So I have different observations, and if we have time, I would like to ask you some questions about it, if we have time.
Well, I'll tell you what I've learned about that, because I'm lucky right now. I work with 6 other glaucoma doctors, so everything gets amplified pretty fast when we all talk to each other, which fortunately has been the atmosphere at our place. So Dr. Godfrey had a case where he had a narrow, an eye kind of similar, and he did a phaco dual blade because the pressure was terrible. He needed a little help. And sure enough, post-operatively, he got what you had. Afterwards, he got a choroidal effusion just with that angle procedure. And that's very limited compared to a GAT as far as the amount of angle open. So we talked about it. And I said, I'll tell you what I want you to try. Instead of the typical arc you do with your dual blade, I only want you to do half. Only want you to open a couple of hours max. That's it. And sure enough, he did that in the fellow eye, and it worked perfectly. No effusion. So the first thing I want to say is, kind of like Ike was saying, you certainly don't want to do anything that induces too low of a pressure in these eyes, because you're guaranteed to have nightmares. And I've seen some eyes, obviously everybody has their horror stories with these eyes with a tube or whatever you may have done. So instead, and there's now some reports in the literature, as you well know, where you can get superciliary fluid after some angle procedures. And I don't think the mechanism is truly known, because you look at these eyes and you don't see a cyclodialysis cleft that you can obviously see that you created. There are certainly cases in the literature where you can make a cleft, but you know, inadvertently. But let's say you look in there, you don't see a cleft, you just did an angle procedure, and sure enough, the pressure goes too low and they get superciliary fluid. And the question is, what came first and how did that happen? So anyway, in a case, my point is, I think opening a much smaller part of the angle than you would normally open in these nanophthalmic eyes is the way I've learned the hard way to approach it. So I wouldn't do a GAT, for example, or if I did a GAT, what I'm doing is I would viscodilate 70%, but I would only open a couple of clock hours with the otomy part. So that's kind of one lesson I've learned the hard way. As in Texas, as we say, you know, a lot of people say, well, I got burned on that case. In Texas, we say, well, I got charcoal.
Yeah. Ron, can I say something?
Sure.
So this case, exactly, I totally agree. This case was non-ophthalmic with 90 millimeter axial length. And in this case, actually, there was no, I tried to go inferiorly during GAT, but there was no Schlemm's canal here. And then I tried superior nasal quadrant and suture hits here. And that's all I did, you know, a couple of hours, maybe 3 clock hours or something. And that's it, together with corneal synecholysis. And this happens. And it's working very well right now. Patients patient is using any no other medications, and this is very interesting. I mean, did you happen to see this kind of observation? I mean, there was no canal, there was no Schlemm's canal in these non-ophthalmic cases. Maybe this is something related to the scleral structure.
Could be.
You have this kind of observation?
Yeah, I think there are cases where, depending on how long the iris may be plastered up there and how long the pressure was high, we certainly know, as everybody knows, you know, you can get herniation of the TM into the collector channels, and that's very well reported, especially by High-End Gong and a lot of researchers. So if everything was stuck against the back wall and it was there long enough to, quote, be cemented, then I could see how you could not get in there with the GAT at all. Yeah. And now, I guess you're also raising the question, in the nanophthalmic eye, is it possible to have an area of the canal that didn't form? That's beyond my pay grade, so I don't know that.
Yeah. Okay.
Yeah, I agree with Ron. I think that these eyes can have just really infiltrative, you know, fibrosis into the TM, and sometimes, you know, you try to do gonocirculitis in these eyes, and it's, usually you do a GSL and you can pull back the iris and tease it away from the angle. But in some of these cases, it's so cemented in there that you pull everything and everything just bleeds, right? Telling me that there's such firm adhesions present, and that's why maybe you couldn't get canalization of the canal, perhaps. And I do think that, yeah, I mean, a small ab internal trabeculotomy, or I particularly use stenting approaches. Typically, eye stents, less involved. Bleeding's often a bigger issue in these small eyes as well. So, no real great answers, and I think it does make you pause. I mean, going back on this now, when you asked the question about should we have intervened earlier when the patient presented with a nice deep chamber and everything, not deep chamber, but a deeper chamber than what you had at the end, whether we should have intervened earlier. And I guess we just don't know the answer to that. In this case, of course, it would have been obviously easier, but that's obviously retrospect. So thanks for sharing this case, Zainab. That is a fascinating case.
Imran, can I make a comment?
Imran's here. Great, Imran. Hi. Thank you.
How are you? Hi, Ronald. So I think Ronald makes a very good point about the supraciliary effusions. I think sometimes when you UBM these patients, even preoperatively, you'll find occult supraciliary fluid as well. And again, and that might be due to the choroidal congestion that some of these eyes get. But I think certainly if you see supraciliary fluid preoperatively on UBM imaging, you need to have your wits about you. And I think the other thing is that, I don't know what happened in this particular case, but I'm quite aggressive with giving preoperative intravenous methylprednisolone, because I think one of the factors that triggers uveal effusion in these patients is inflammation. And so with the GATT or an ab interno trabeculotomy type of procedure, I would say is more pro-inflammatory than a phaco alone. So that might be the other reason why you got uveal effusions in this case. So that's just another point. And one other thing, I know you mentioned stenting. I think what I found in angle closure eyes, particularly again, if you look at the iris morphology where the iris inserts, sometimes some of these eyes have high iris insertion. So what I found sometimes is that the stents get blocked with iris. And so I found that canaloplasty, so again, something Ronald Feldman said, I think canaloplasty combined with lens extraction and angle closure is particularly beneficial in my view. Thanks.
Yeah, great points, Imran. And I think, Zainab, I don't know if you published or I know you've spoken about just the performance of GATT. And I think actually Devinder Grover spoke about it too, and Ron, you have as well. Just particularly with a suture trabeculotomy, there's some traction at the iris root. And this perhaps creates some micro clefts, if you want to call it. And that could be another mechanism beyond what we just spoke about. So a lot of different possibilities that may exist. And I agree with you, stenting and any trabeculotomy and angle closure, there's a risk of iris, adhesions. What I sometimes do is I honestly, I don't like to do that, but I keep them on pilocarpine for some time, or even I'll do some iridoplasty at the time of the procedure. So actually taking a diathermy and cauterizing the peripheral iris in that area, but that creates more inflammation and everything else. So these are all great pros. And so Imran, thank you for joining us. I heard you had an urgent case in the OR. Don't tell me it was a 60 millimeter eye. Zainab, show them the picture of your AC before you started, just to show this case here, Imran. This was a fascinating case that beautifully shown by Zainab. Wow. Of a 60 millimeter eye. Yeah. And basically an AC that was about probably 0.5 millimeters or so it looked like centrally. Wow. So there you go, Imran.
Good case.
So Imran, I introduced you earlier, consultant at Birmingham, and really a fantastic glaucoma intersegment surgeon. I've had the pleasure of Imran joining me here, and I miss you here, Imran, on your visits here. Really brilliant thinker, as you've heard already in this few words, and has done a lot of great training and innovation. He's been a brother in some of the new surgical innovations, but also a very thoughtful clinician in terms of building the right case and the right evidence for what we need to do. So, Imran, thank you for joining. I know it's midday for you in England. How are things in Birmingham, by the way? How are things in England?
Things aren't too bad. I think we've kind of tried to get back to work as much as we can. Obviously, there's hotspots emerging in various places, and various cities are being locked down as and when. Birmingham seems to be okay at the moment, but I think it's anyone's guess which way this is going to go. So I think our government was probably not as quick on the mark as we probably ought to have been. But I think at the moment we're trying to avoid a bigger second wave, but it's anyone's guess which way this is going to go.
Yeah, for sure. And I just want to also, I see Ahmed Mansour is here. Ahmed, I see you. Are you able to hear us? Unfortunately, I can't hear your voice though. You might be still muted or something. Actually, you're not muted, but Ahmed, are you calling us from Lebanon? Oh, we missed a signal. I think it's incredible that we have, I can't hear you yet, Ahmed. I'm sorry we can't hear you. I think the audio connection isn't there. But Imran, why don't we get you to start your case? And Ron, I mean, I hope you can stay on if you can. I kind of intruded your morning breakfast, but it's an amazing time to have you here.
No, I'm in.
Okay, great, Imran. I want to hand it over to you. So thank you for joining us, Imran. And
pleasure. Let me just get my screen sharing started. Just 1 second.
And Zainab, I'd love to get your input on Imran's case as well, of course, if you can stay on board.
Sure.
Sorry, just give me 2 ticks.
I think that your case.
Sorry, I just need to quit at the moment because I think my settings are
no
right.
problem.
So I'm going to quit and come back in 2 seconds. Yeah,
no problem. I was going to say, Zainab, I would say that I don't know about you, Ron. I don't know if I've seen really shallow chamber. That's probably one of the shallowest chambers I've seen. Really, I mean that's a record.
I mean that is the kind of case you look at and you sit there and go, let's see, how many stents do I have in my heart? I got to think about this. But the interesting thing that Zainab noticed was afterwards, she didn't get exactly what she thought she would from the anterior approach. So the smart thing there was she got together with the retina doctor, because sometimes that happens no matter what you do. And oftentimes though, the anterior approach will fix it. So it's interesting that it wasn't exactly what she wanted and how she handled that.
That is interesting. I was going to ask you, Zainab, I mean, how much, the video got cut off there for you, but how much vitrectomy did you do? When you went through the iridectomy, I think you're muted. Sorry, you're muted, Zainab. You're muted. Let me unmute you.
Yeah, I went through the PI and then did some, vitrectomy, but it wasn't enough, that's for sure. I mean, I used to go ahead and do pars plana vitrectomy, but in this case, the visibility is not good. There was corneal edema and the lens was huge and the pupil was so small. So I just, I was in between. I decided to go ahead and do lensectomy with anterior approach. That was another reason. Yeah, no, sure. And I agree with you, Ron. I mean, I usually find a good anterior approach is usually enough. And maybe it's a function of just how much do you remove and how comfortable the view is. But even doing one, sometimes these iridectomies and IZHs can close up with fibrin or inflammation. So we have to be mindful that if it does shallow still, that you may have to go back and do more. Imran, I'm going to hand it over to you, buddy. Small lens, big pressure. Thank you. I think let me unmute you here. There you go. I think you're still muted there, Imran. Let me get you to unmute there. Looks like your video is working, but your audio isn't. Still, Can you hear me now? There we go. Now we got you. Okay, that's great. Thanks. Thank you. Okay, so we'll dig into a case straight away. So this is a 19-year-old. I'm sorry, Imran. Now you got to share your screen. You're almost there. Oh, okay. Sorry, man. No, that's all right, man. Just 1 second. And Ahmed, are you able to hear us still? Ahmed Mansour. I think we're not able to get audio connections with Ahmed. Okay, good to go. Now we're good. Perfect. Okay, fantastic. Great. Okay, so let's dive in with the case straight away. So this was a 19-year-old Pakistani female who was originally seen in our unit in 2015. At this point, didn't come in under my care, came in under a colleague. And she essentially presented with blurred vision in her right eye, and the acuities are shown there,
with high pressures in the right eye, and the initial gonioscopy showed 360-degree iridotrabecular contact in the right eye with an open angle on the left side. Just some of her testing. So her refraction, she was minus 20 in the right eye, minus 10 in the left. Average Ks on her cornea. And the axial lengths were slightly different, but certainly not enough to explain that degree of refractive imbalance. These are our OCTs. This is the left eye. This is the right eye. And the right eye, you can see that shows fairly significant glaucomatous cupping. This was her UBM. This is the left eye. And you can, if you look at the right eye, you can see that the AC is shallower. The surface of the lens looks more rounded. And, you know, if you look with the eye of faith, just here, this is actually the lens just there. And the comment that the ultrasonographer made was that the zonules were elongated and the lens appeared spherical. So this is what we call microspherophakia. This is the UBM showing angle closure. There's the iris jammed up against the trabecular meshwork. And what you can see here is this is the other eye. But again, you can see probably what we refer to as a little bit of angle dysgenesis in that the iris insertion is quite high. The ciliary processes are a little bit small and abnormal. So what we're seeing here is a triad of refractive or lenticular myopia, angle closure, and a shallow anterior chamber. And this is unilateral spherophakia. This is quite rare, quite an unusual case with angle closure glaucoma in her right eye. Now, the question is, what do you do in terms of management? She's got high pressure, she's got disc damage, she's relatively young, and various options are obviously available. And my colleague started off with medical therapy, and then there was some procrastination about whether laser iridotomy should be done, should a surgical iridectomy be done. You know, the other issue with some of these Afro-Caribbean or Asian eyes we find is that sometimes you can get quite a lot of inflammation after laser iridotomy as well. So people can be a bit reluctant sometimes to do that. And then of course there's the question is whether you do lens extraction. That would require quite complex surgery with CTS, CTR. Or are there any other options? Now, if we look at her sort of timeline, you can see this is when she first presented in January 2015. She was put on medical therapy in the form of latanoprost and brinzolamide. Her pressure settled down, but then she became refractory again quite quickly. And the problem here is that obviously the underlying iridotrabecular contact is still continuing, and she's got ongoing damage to her TM. So that hasn't been reversed during this point in time. So the obvious thing is that her TM dysfunction continues and her pressure goes back up again. More medicines are added there at this point, and then again, over a fairly short space of time, over about 6 months, the pressure goes back up again. And then she ended up in a joint clinic that we run in Birmingham, where they asked my opinion. And this is just to show you the contralateral eye. This is the left normal eye where the pressure has always been normal with no problems. So the issue now is she's got a chronic history now. She is seen by me now, but she's 3 years post-presentation. Should a PI have been done earlier? There is already fairly significant disc damage in a fairly young patient. And there is always the question of, you know, what is the TM function like at this stage? Although she hasn't developed, what I haven't mentioned is she hasn't developed peripheral anterior synechiae, but there is a question around TM function. There's obviously the risk of lens extraction. She's in her 20s. It's not an easy case, and there's always the risk with intraocular surgery of this sort. And the question is, if you do take the lens out, would you actually affect the intraocular pressure significantly? So I have to say, in this case, I went with a trabeculectomy.
Imran, I'm just wondering, Imran, before you go there, I'm just wondering. I mean, I guess you've tipped your hat in terms of what you did first, but I'm just curious what Zainab and Ron. I mean, any comments on this case, presentation wise, and also in terms of how you'd approach this?
Zainab, go ahead. You can go first.
First, so she had PI, right?
No, she didn't have a PI done. So what happened was she came in under a colleague of mine, and I think she was basically sat on for 2 or 3 years. And then eventually, when the pressure became refractory to medical therapy, we run a joint clinic, and she was brought to that clinic to ask for my opinion.
Okay, so this is advanced glaucoma. We have significant disc damage in a young patient. So probably I would go for lens extraction.
Yeah, just a question here, Imran. I'm curious about the other eye. I mean, in the cases I've seen with the young, likely congenital, microspherophakia or spherophakia case, Will Marchesani, as Steve Stafford mentioned, can present like this, but I presume she doesn't have the data of Will Marchesani, so that's out.
Yeah.
Usually there's something, and she was -10 in the other eye.
Yes.
With a 24.5 millimeter eye.
Yeah.
So I imagine there's probably some element of similar syndrome. I'm going to presume that, but not as severe, right? I would presume.
Yeah.
And
possible. Yeah.
Possible, yeah. And second thing is, so the angles are open when you're seeing the patient, and the pressure is high still, right?
No. So when I saw the patient, in the right eye, they had not done a laser iridotomy or anything. So I saw the patient at the point when the pressure became unstable again in the context of no previous intervention having been done.
Got it. Yeah.
So she'd been on medical therapy for 3 years, and then they just said, let's get another opinion, and then they sent her to me.
So I guess the question is she getting, I mean, and these lenses can be really mobile, right? One day they're like sitting nice and back. The next day they're like pushed forward.
Yeah.
And you wonder, is she getting intermittent IOP spikes from angle closure?
Yeah.
Or, and I agree with you, you can't assume that, because I think these patients likely have some sort of underlying angle anomaly, as you kind of alluded to earlier.
Yeah.
And simply treating the lens may not be enough. It may not be enough. And so that's a conundrum we're in. Regardless, though, the lens is going to continue to be an issue. And so it begs the question, should we try to go lens first and maybe do an angle procedure and maybe have enough control and then move to a filter first? Or do you do a filter first because she's got severity? And I think that's the question you're asking. And I think it's not an easy one. Maybe I'll get to Ron. I mean, go back to you, Ron. What would you suggest here?
Well, I've never seen, I don't think, a strictly monocular microspherophakia, and this is my 36th year of doing glaucoma. So I've seen a fair number of bilateral microspherophakias, and usually it's wild Marchesani or some variant, and they're nightmares too. So I think the iridotomy is a thought if they look like they're going in and out of angle, of pupil block, because that's usually the mechanism is pupil block induced from microspherophakia. But it sounds like when they looked at the eye before, maybe it didn't look like that. And maybe that's why they didn't do a PI. I'm not sure. That part's not real clear, but
Ron, when they first saw the patient, the first entry in the records does say that she had angle closure in that eye.
Oh, okay.
Yeah.
So obviously early on, my thought process would be early on to do the iridotomy, because certainly that's what we've done in young people that we see who come in with microspherophakia and narrow angles. The iridotomy oftentimes will take care of it. But oftentimes, even after the iridotomy, you still have a pressure problem because they may have some other mechanism going on as well. But I certainly like Imran's approach of knowing, okay, this is bad glaucoma now. If I just did the iridotomy or maybe just did the lens, it maybe is not enough. And that I have a feeling that's why he's going towards something more aggressive, like I'm assuming he's doing some kind of trabeculectomy or something that's going to do an iridectomy anyway at the same time, which should negate the problem with the lens if I understand the mechanism at this point correctly.
Okay, great. So I think you had great comments. I mean, my only comment would be that just doing a filter alone, I mean, you still have the lens issue, and you can still get, anterior movement of the lens and potential issues in the anterior chamber. So I guess the consideration would be to combine that. My vote and my bias, of course, is probably to skip the trabeculectomy first and go after the lens, probably put some eye stents in just to kind of get some TM control. Although I will tell the patient there's a 30% chance that they're going to need to have a filter, just as a ballpark figure. And I do agree. I don't like doing a PI in advanced glaucoma. I think the risk of having a significant intractable IOP spike is quite high, and you need to get in, do something more definitive. So I think it's controversial in these eyes. I agree, but that's the consideration. So Imran, back to you, buddy. I think you have some great thoughts about this.
Okay, so we went ahead and did a trabeculectomy, and I think that just a few points to mention here. When you're doing trabeculectomies in these sort of young eyes, these eyes can be very hyperelastic, and there's quite a significant risk of hypotony if you're not careful. So we measure out the flap quite carefully, and you really check what thickness you're dealing with here, because sometimes we'll get our ultrasonographers to tell us what the thickness is in the anterior sclera. The other important point here is that you've noticed that we don't make these radial cuts. You don't take them so far as you would normally with a conventional trab. Again, the risk here is if you end up with a large radial cut, you'll get more profound leakage from the side. So it's just, again, really approaches to minimize hypotony in these more complicated trabeculectomies. And then once you've got your depth, you obviously create your flap. And then I like to use releasable sutures as here. And, in essence, we've put a couple of releasables into this flap, and we've shut the flap down. So, this patient should do well and not have a problem post-operatively. And then I like to use nylon when I close the conjunctiva here, again, because it excites minimal reaction. And you can see here, look, minimal hemorrhage, and that's really critical because obviously bleeding causes fibrosis. So that's the trabeculectomy done. And she initially,
Imran, you did an iridectomy here, I presume, right? Is that?
Yes, iridectomy's been done. Yeah. I didn't show that. Yeah. So again, I think the point that Ronald made is a good point, which is now that the iridectomy's been done, the angle has also opened up. So that ongoing iridotrabecular dysfunction or iridotrabecular contact is no longer there. So now the problem is that her trabeculectomy worked okay for about 9 months, and then her pressure went back up again. And so let's look at why the trabeculectomy failed in her. She's a young patient. She's of Pakistani origin, and obviously ethnicity increases the risk of failure. And here's the other issue. I think, again, when you've got a young patient who presents with advanced disease, you've really got to think about, if you're going to do a filter, you've got to think about doing a filter early on. She was on preserved medication of various sorts for about 3 years. So again, another risk factor for failure. Yeah.
I'm going to mention one more thing, which I've seen, and I've seen this in pseudosfoliation eyes and also these eyes, is that there's intermittent iris contact.
Yeah.
And I often see, I don't know if I should have asked you this earlier, what the pigmentation was in the angle, but I think these patients do get iris chafing. They do get some, I won't call it UG syndrome, but they get some reactions sometimes. And I just wonder whether that also may have contributed. There
wasn't any obvious pigment that you could be visualized in the eye when we examined her, and apart from appositional closure, there wasn't what I would call heavy pigmentation of the angle.
Okay.
Did you use mitomycin on the filter?
Yes, 0.4 milligrams per mil for 3 minutes.
Okay.
Yeah.
And there's a comment, and there's a comment here about the trab did not fail. The glaucoma mechanism wasn't addressed. A provocative statement, but an interesting one.
Yeah.
The trab did not fail. The glaucoma mechanism wasn't addressed, which I think is a good consideration, or at least a point of discussion, I guess.
Although the mechanism of glaucoma is far from clear in the eyes like this, So, okay. So we went ahead with a needling procedure here, and I'll just show you the needling because I think it's important just to sort of show how needlings are done, and obviously people have different techniques. So this is using an insulin syringe. You go as far back as you can, and then make sure you don't obviously perforate the conjunctiva. And here we ended up in the anterior chamber, and it's a fairly aggressive needling. I find in young people you do have to needle very aggressively when you do needle. And there you can see that the bleb's forming quite nicely there, and we're just checking that the intraocular pressures come down. And you can actually see the bowing of the iris there as well. And then subconjunctival 5FU and dexamethasone either side of your revived filter.
Interesting. So Imran, I just a question about mitomycin versus 5FU when you needle. Any thoughts on that?
I have to say I tend to use 5FU. I've never used mitomycin. I know there's literature out there which suggests that mitomycin may be more efficacious, but I've certainly in my practice I've found that that 5FU seems to work okay. So I've not felt the need to change.
And Zainab and Ron?
5FU.
5FU for Zainab, Ron?
Well, you know, what we have tried, and there's so many ways to needle an eye, it's crazy, but we use a little spatula and do an ab interno revision. Granted, you can see the stoma, the sclerostomy site, on gonioscopy preoperatively. So in the operating room, we have a little spatula that we worked on because, you know, we used to use a cyclodialysis spatula, but it wasn't quite long enough. And we go ab interno using the, in fact, we use Ike's gonio lens, a gonio prism, because that gives us the best view and you can rotate. It works perfectly for that. And then we go inside the sclerostomy site, and then we put traction on the globe and we just wiggle our way subsclera and we just come out the other end. So it's just another way to open it. And I tend to use mitomycin on these as well. So you can either open it ab interno or ab externo, as in this example, what you're most comfortable with. And then I still use mitomycin. And the other thing I'll mention is if this failed, we have a fair number of cases where we've done something like similar to a GAT in these eyes that have failed trabs, and they still work in a lot of young people. So the key is this person is I think this person was young. And so I wouldn't give up long-term on an angle procedure, even in a failed trab in a young person, because their mechanisms, as somebody mentioned earlier, are usually different as far as what caused their glaucoma. Great.
Okay. Great comments on the chat group as well, but I'll let Imran continue with this very interesting case.
So this is a post-operative course, and this is following the needling. The pressure comes down, and she's actually been controlled now for the last almost 2 years with fairly stable visual fields. So kind of this is where we are at the moment. This is the visual field in the left eye. This is the visual field in the right eye, and that's my case.
Okay, great. So we've got various approaches in this case. I don't know if Ahmed, are you able to still to speak? I'm sorry. I know it's probably difficult where you are.
No,
unfortunately not. Ahmed is in Beirut, so it's actually quite a privilege to have him here, and we certainly are praying and thinking about all the tragedy we've seen in the last 3 days in Beirut, and may God bless and protect your families and your loved ones. I'm sorry we can't hear you, Ahmed. Ahmed is a very a great colleague from Lebanon who has contributed a lot in our literature. So I'm sorry we can't hear you. Okay, I just want to open it up a little bit more for just general discussion. Thank you, Imran, for sharing that. I mean, there are different ways to look at this. This patient's fortunately, it looks like this patient's field was still pretty retained, which is good news, despite the fact they have severe cupping, which is often the case in these young patients. There are a lot of comments that have come on the line about saying, you know, why not address the patient with a lens procedure and an angle procedure. As Ron said, usually in our experience with younger patients, we usually go angle first, even without the issues around the lens. Just a juvenile glaucoma, for example, that generally our first approach is to go angle first, and not just congenital, but even like a 25 or 30-year-old. I don't know what you think, Ron or Zainab, but that's kind of been our first approach. And although it isn't always successful, it may prevent the need to go to a bleb, which of course introduces long-term potential risk. So I'm just curious. I'll maybe let Zainab and Ron speak to that first, and then come back to you, Imran, about choices here. Which again, there's no right answer, of course. But Zainab, what are your thoughts on your approach in dealing with?
As I said, I would go for lens extraction first. I would take the lens out and then check the angle. And angle examination is very important in those cases because some of them might have also dysgenic angles in patients with microspherophakia. So angle procedure makes sense in those cases. So I would take the lens out first and then check the angle and follow the patient very closely, and then maybe add some angle procedure like GAT. And I aimed and I go for 360 GAT, not hemi-GAT, because this is a very advanced case and young patient. That's what I would do.
Ron, your
Yeah.
comments?
Sure. Well, you mentioned something important, Ike, and that is that, you know, what age is it where you kind of say, wow, a GAT might be, or some type of angle procedure might be overly effective, so to speak, which is hard to say in glaucoma because just about, you know, most things we do don't work all the time. But I find up to age 40 seems to be what I call juvenile glaucoma. And the cutoff varies in the literature. Some people say 35, whatever. But if I see a young, you know, a young person, which I'm calling up to age 40 now that I'm 69, I find that they do better than somebody who's my age. And I think Zainab mentioned the reasons why. And whether or not you do whatever you're good at in the angle, I think is worth doing on a case like this, like Imran's case. And even if this trab failed, the revision, the needling, I would consider an angle procedure because whatever caused the microspherophakia in embryologically probably is related to a little bit of a goofed up angle outflow. That's the way I think. It's exactly what Zainab was saying. But I go up to, I think, age 40, and most people don't really think that high, but I think that's a reasonable thing to think. I'd be interested to see what you guys think about age 40.
Yeah, I have to say I was not a believer in what you just said. And I've become a believer over the years, and particularly with GAT. I mean, not so much stenting. I think these patients need to have a trabeculectomy done, and stenting isn't enough in these cases. And I think, as Zainab said, you know, I think the younger they are, the more likely I'm going to go 360. And for the reasons you kind of mentioned in these eyes, that I'd likely have some dysgenesis going on here. They seem to respond. Now, many of them don't, but then I go on to do a trab or a bleb procedure, and I think I don't know. My bias is clear. I want to avoid blebs, not at the expense of glaucoma progression, but long term in these young patients, they're going to need to have multiple procedures, and they're going to need to have probably multiple conjunctival procedures. And if there's even a 30% chance or 40% chance that an angle procedure may work, it's something to consider. And again, there's no clear evidence. I don't think it's wrong to do one or the other, but that's been my general approach. And I probably, you know, again, being, you know, and again, Imran is absolutely right. These procedures can be very difficult with these lenses, right? These lenses can be moving around everywhere. The vitreous comes forward, retinal detachment. So it's easy for us to say lensectomy, and then all of a sudden you're dealing with retinal detachment and loss of vision. So by no means is this there. And some of these cases have a higher risk for retinal detachment. For example, with Marfan's, just touching the lens. So I think it's not an easy situation to do, and I don't think it's right or wrong to do one or the other. So that's kind of what I would say would be the thought on that. But I mean, back to you, Imran, and this. I know Ahmed just messaged me. He says the internet is unstable due to the big nuclear explosion and to the current 1 million demonstration downtown clogging the internet. So it's almost a miracle that we can see you, Ahmed, that you're here with us, and that you're able to participate and talk. And it's a real honor. It's a real honor to have you with us, with everything you've done in glaucoma, and also with what's going on in your country and in your city. And I think all of us are thinking and praying for you, Ahmed, and your family and your friends, and we want to help in any way we can. So, but thank you for being. I'm sorry you cannot speak. I know the internet is not good. Imran, I want to give it back to you, buddy. I mean, it's you know,
yeah,
I think some thoughts on this. Great thoughts on everything on this. But
no, I think some great thoughts and some great reflections. I think, I've been doing GAT for about 3 years now, and I think that I would certainly concur that when you've got your run-of-the-mill juvenile open-angle glaucoma, you know, high myope, deep anterior chamber, that is definitely the go-to procedure. And I would say that of the 10 or 15 that we've done, the vast majority have actually done very well, and pressures are controlled on very few medications at about 2 or 3 years. I do think in this case, though, the reason I didn't go for that approach was what Ike has just alluded to, which is the issue around, it's not just a simple case of doing a GAT, it's a very complex lens extraction plus you would be doing some sort of angle procedure. And if you do end up with vitreous coming around the zonules, one of the problems is and I've done gout a few times in patients who have a unicameral eye, so to speak, because they might be either aphakic or they might, and you do end up with, or if they've got zonular defects, you do end up with vitreous hemorrhage as well. So again, in a young patient ending up with a vitreous hemorrhage, when you combine this with a lens extraction, maybe, wouldn't be such a good idea. So I think all things considered, I understand the bias that some people may have, but I think all things considered, we felt that the best thing for this patient at this stage of her glaucoma journey was a filter.
Mm-hmm. One question Maria Delgado's asked, what about a tube? Would you consider a tube first line?
I generally don't in these sort of scenarios. I think one of the issues here is obviously the angle. I think that to the point that Ronald makes about if the trab does fail, obviously we can try needling again. But if we end up in a situation where we can't resurrect the bleb, then I think lens extraction and an angle procedure would be the right choice, because then that deepens up your chamber so you can then put a tube in. I think I don't think that putting a tube in an eye with a lens that's mobile like this one is necessarily a good idea. So I wouldn't have gone for a tube in this case.
Great. Yeah, great thoughts. And I think at the end of the day, I mean, there are different ways to deal with these cases. And I think that we all have to decide what is the best procedure in our hands, right? What works best for Ron is different than Imran, different than Zainab, different than Ahmed, different than Maria or Steve. And I think that's a big factor. Now, of course, we have our own biases, no question, and our own anecdotal evidence, so to speak, that we all tout as being the answer. But I think it just shows that it's good to see multiple approaches. And I think that, as many of you know, I mean, we've done a lot of lens surgeries in zonular cases. And I know Steve Safran's on the line here and has made some comments. And I would definitely do everything I can to retain the bag. If you're doing a lens procedure, retain the bag. And I think that's really important to maintain, the anterior hyaloid face, and that reduces some of the risk of complications. Some of the older studies of Marfans specifically have shown that once you engage vitreous, the risk of retinal detachment increases 40 times. So not engaging vitreous is a key principle, and it is challenging in these cases, but in these young patients, for the most part, the vitreous is pretty formed. And so if you keep the chamber formed and you work in the bag and you're able to pass sutures, anteriorly, then fortunately we're able to do that. We're lucky enough to have long-term results on these cases. I also recommend in these cases that simply a CTR is not enough, because these eyes will still end up having shallowing and the zonule moving back and forth and causing intermittent angle closure. I got burned on that many years ago with a milder case of spherophakia where, lens came out fine, zonules were not too bad, CTR's in, and then the bag's still moving and the patient's getting intermittent pressure spikes. So I think that's one consideration. So those are I think great opinions. Lens removal with angle procedure or going to a filter is what we're looking at here in these cases. I just want to make sure we just get a couple last questions here. Thank you for showing the needling video. Any needling tips to avoid bleeding? And what gauge needle do you use, and where do you inject your steroid and your antifibrotic? Just quick thoughts on that, Imran.
Yeah, so I use an insulin syringe. I think that's a 30 gauge, so just a standard insulin syringe. And tips to avoid bleeding: adrenaline or preoperative aproclonidine helps as well. That can constrict the anterior segment vasculature. And where I inject, and there's no specific site. It's just either side of the newly formed bleb.
Okay, great. All right. Well, those are two really great cases, and I think the best part of these cases is how much we generate in terms of the discussion, right? Which is what we've witnessed here. So, and we have a truly international cast of speakers, which has been great. I'll just pass the mic around for last comments, and maybe we'll just start with Zainab since you presented first. Thank you, Zainab, for being here and always sharing a lot of great pearls. I mean, you had a lot of curves managing that cases, man. I mean, I generally, I'm pretty lackadaisical in the OR, with another case, whatever. I would certainly be up a little bit at night thinking what I'm going to do in that case. And I would be, as Ron said, I would make sure I've got extra protection in my coronary arteries, managing that case with a 0.4 millimeter AC depth centrally. So congratulations on that. But any comments about nanophthalmic angle closure, or also microspherophakia and glaucoma?
I know. Thank you. Thank you for the invitation. It's been a great discussion as always. So thanks for giving me a chance to discuss. I've learned a lot. Thank you. Thank you for all.
Well, thank you. Stay safe and be careful at the beach there in Turkey. I hear it's really crowded.
Exactly.
So Ron, you're in the Big D, Dallas, Texas.
Yep.
You guys never shut down, man. Texas doesn't shut down.
No, it's you're right. You're right. But I think, if you think about take-home messages, excuse me, Zainab's case was really amazing. And it makes you think about how do you handle the nanophthalmic eye? And I like the idea of when you said you go to the operating room and you use mannitol, you be prepared for an ICH. And thinking ahead, these cases is just critical, how you approach it in the operating room. And that case that she showed was scary. I mean, that was really amazing how she handled that case. So I like, and the idea of a monocular microspherophakia kind of case is, again, a great case to think about how you're going to handle it. So, excuse me, I like the idea of the two cases that were presented and how people can think about how they approach them differently. Totally different, good ways to think about how are you going to approach it. And I think there's a lot that was learned, at least I learned a lot this morning. And the thing about when you do scleral windows, I think is also a good take-home pearl. And these eyes that are, I think you said, Ike, if it's less than 18, you like to do a scleral window. I think that's a good take-home lesson as well, because I love the UBM in our practice to look and see, is there suprachoroidal fluid? And I'm one of the first to recommend a window. So I think the windows are underutilized.
I agree. I mean, in the old days when of extra cap, I mean, it was almost gospel to do windows. And then when we went to phaco, I think we kind of found that maybe they weren't as important. But in these small eyes, I just had, just enough cases where I think, they're needed. And I think also, I mean, unfortunately, imaging isn't always available around the world. But man, a B scan and a UBM and endoseminal CT are so valuable in understanding, these cases. And I think both Zainab and Imran have spoken about getting to the bottom of the mechanism, right? That's why I love glaucoma the most. It's because we need to talk about mechanisms, about what's causing the elevated pressure, what's causing the problem in the first, what's causing the glaucoma. And I think that the deeper we get in that deductive reasoning process, analytical thinking, the more we're able to tailor the approach. And it isn't always perfect, of course. And so I think both of these have illustrated the need to really get down and get the mechanism. And even don't take for granted somebody comes in with glaucoma. As Ron said, the first thing he said was, something doesn't look right here. I have to kind of take a step back here and just, what's going on here? And same with Imran's case. So both cases have demonstrated these really well. Imran, I'm sorry you couldn't catch the first case, but just maybe your general approaches in nanophthalmic. When do you do an IZHV? When do you do scleral windows in general? Any general thoughts on that case, and then just in general?
I think first of all, I thought Zainab's case was fantastic. The latter end that I caught of it, and I think my thoughts are, a couple of points. Is that with these eyes, I tend to try and do them under general anesthesia. And one of the things that I've learned is that if you ask your anesthetist to try and get the PCO2 to be somewhere around 4 or just below, that does help in causing choroidal vasoconstriction. So that might also help with reducing the forward pressure that you get. And then occasionally what I'll do is, if I'm doing a case under local, we use something called a Honen's balloon to just allow the anesthetic to spread. And again, the pressure, if you leave that on for a little bit longer, so maybe about 10 minutes, that is enough to sort of compress the vitreous and reduce the forward pressure that you might get. So those are a couple of 2 points. And the other point I made was using intravenous methylprednisolone and mannitol, to try and reduce the risk of inflammation, which I think is critical in driving choroidal effusions. And in terms of eyes, I have to say that I don't routinely do a hyaloidotomy, and I won't routinely do scleral windows. So I haven't done a huge number, but I've done a number of eyes ranging from about 14 to about 16 or 17 millimeters. What I find is that what I tend to do is if they go into malignant, I'll then go and do an anterior transonular hyaloidotomy. So I don't go through the pars plane. I'll make an incision in the cornea and go and do an iridectomy and then go through there. I think the other thing that to remember is that these eyes get very inflamed. You need lots of steroids afterwards. I mean, you can't give these people QDS, Maxidex or something like that. You've got to give them. Sometimes I'll give them, particularly if you do a GSL or you manipulate the iris in any way, I will give them hourly Predfort, something really strong, and sometimes even oral steroids. And then, of course, the other thing that these eyes are very prone to developing is macular edema. A lot of them have occult maculopathy as well. So, I'll hit them hard with non-steroidals. So I think the pre and post-operative management of these eyes is just as important as what you do during surgery.
Yeah, fantastic pearls. Absolutely. You're so right. I've had beautiful cases of resolving the pressure, and these patients have, difficult CME, or they develop an ERM. And these patients are at high risk for that. I think it's worth warning these patients that this is something that they may see. So really wonderful pearls, and you put it together very well. Thank you all for joining. I mean, these are both really great cases that are illustrative of different options. I think that as glaucoma surgeons, we've got to be, the best lens surgeons in the group, as many of my preceptors and mentors have said as well, and colleagues have said. Whether it's dealing with a difficult angle closure or weak zonules, these cases require really, the ideal technique and the instrumentation and the approaches. So thank you for sharing. We'll be continuing these. Imran, I do appreciate your time. Thank you. I know that you are in the OR as well. What was the case, by the way? Was it a good case? I hope it went well.
No, it was nothing exciting. It was just it was a globe rupture. Some poor chap was trying to take something out with a knife, and the knife ended up through the upper lid into his globe. And so I just had to start off the case and get the trainee sort of comfortable before I left.
Okay, hopefully it'll end. That sounds pretty nasty.
Yeah.
And Zainab, again, thank you for joining us as well. And stay well, stay healthy.
Thank you.
Ron, I saw your name up there, so I want to bring you in. And you add so much depth to the conversation, man. You're a legend in our community, and when Ron Feldman speaks, we all listen. So thank you for all your contributions as well. And everybody on the chat group, thank you for joining. Ahmed, I wish I could have a chance to speak to you. I know you can't speak, but we really are with you, and want to everything we can to help. And we really pray that the situation improves. I mean, what a unbelievable tragedy watching what's going on there. So please stay safe, stay healthy. I hope your family is okay and your friends are okay, and keep in touch with us. And I hope we'll have you when things are a bit more stable to contribute to our rounds. So God bless you, Ahmed, and thank you for all your contributions. And really, you're on all our minds. You're on my mind every day. I'm thinking about what's happening in Beirut and the folks in Lebanon. So God be with you all. Thank you. And to everyone else, thank you for joining us at Prism Eye Rounds. We will be back next week, we said, on Sunday, different day, same time, Sunday, 8 o'clock. I hope that you can join us. And if anyone's interested in being on the panel, let us know. Imran, Zainab, and Ron, I hope we can have you back at some point as well. And I hope I'll be able to see you guys in person at some point in time, although probably it looks like it'll be sometime next year. So thank you, everyone. Enjoy your weekend. Thanks for spending time with us today.
Thanks,
Everybody, take care.
Safe.